Thank you so much. A very good morning to all of you. At the onset, let me thank all the organizers, Tarun, Anmol, Ashish, and Dr. Das. Thank you very much for having me here. I'm the only radiologist amongst all you eminent surgeons. So I'm going to be talking about MR and how it helps us in seeing the anatomy and how do we delineate the fistulas. So initially, there were a lot of imaging modalities available, endoscopic ultrasound, fistulograms, which were done to evaluate fistulas earlier, but they all had their limitations. Endoscopic ultrasound was excellent to show you the internal opening, but the field of view was very small. So the knowledge and the information we got was very limited. Fistulograms basically were now absolutely outdated because they cannot give you the sphincter anatomy very well. And of course, the associated complications are not seen. So MR is now emerged as the tool, the imaging tool and the gold standard for pre-surgical evaluation of fistulas. And why is that so? It gives you excellent soft tissue contrast. It is not dependent on the operator like ultrasound. It has multiplanar capabilities. It has a wide field of view and precise radiological information about the location of the tract and the affected pelvic structures can be given. So what is the role of a radiologist and what are the goals of MRI? It is basically to tell the surgeon where the internal orifice is. The external orifice is seen clinically, you're not interested in that. Show you the exact fistulous route, the caliber of the fistula, are there any extensions, are there any other adjoining structures involved? And if the surgeon knows all of this, there's of course very good surgical outcomes. So MR is helping the surgeon to adopt the best surgical strategy. So for those of you who are not familiar with MR and how we do it, there is no preparation required. We give no enema, no antiperistaltic agent, no fasting is required. We have 2-3 Tesla machines, we use those. But even 1.5 strength Tesla machine is adequate. We do not place any endorectal coil. Lots of surgeons ask us that. So there is no discomfort to the patient. All the patient has to do is lie in the machine. And the protocol we do is very important. I'll show you why it's important. We use different protocols and contrast is optional. If you give IV contrast, the delineation of the fistula is excellent. But even without contrast, it's excellent delineation of the fistulas. And we do not instill any fluid, any dye into the fistula at all. So in short, no preparation is required. You just send the patient to us. All he has to do is lie in the machine and we give you all the information. So now why are sequences important? So if the protocol is not done right, you will be missing fistulas. So now this is actually a coronal image which is fat saturated. By fat saturated we mean the fat is all dark. This is the fat in the gluteus area, it's dark. So we really can't see a fistula. But if you look at the non-fat saturated images, you can see the fistula very well. This happens when the fistula is fibrosed and there is very little fluid. So in retrospect, you can see that there is a fibrosed fistula. Then you'll ask me, why do you do these fat suppressed images? We do this to see the fluid within the tract. So if you see the ones without the fat sat, the fluid within the tract is not well delineated. However, if you do a fat saturated image, you can see the fluid very well. So we have to have a combination of all these images in all 3 planes to give you the exact delineation of the tract. So let's come to anatomy first. We had beautiful lectures in the morning about anatomy. So exactly what you see in cadavers on your book pictures, that's exactly what we can show you on MR. So if you look here, this is the internal sphincter. Internal sphincter is intermediate in signal and it's the continuation of the circular layer of the rectum. So you can see the layer very well. The external sphincter, all the 3 components, that is the subcutaneous, the superficial, the deep, are excellently dilated on MR. You can see the puborectalis sling and the levator ani muscles very well. And on either side here is the istioanal fossa, which has the fat. And in between the internal sphincter and the external sphincter, you have the intersphincteric space. So nothing is left to the imagination. You can see the anatomy really, really well. The same thing in the axial plane. You can see this is your external sphincter, the dark one. What you see in between is the fat in the intersphincteric plane. Then this is the internal sphincter, and this is the fat in the istioanal fossa on both the sides. Sagittal images also we acquire. On sagittal, what we see is actually the where the anal verge is. Because whenever we are giving you a description of a fistula, we will always tell you the distance from the anal verge. So this is how you measure. Where these vertical ones become circular, that is the part of the anal verge. Another question surgeons very commonly ask us, how far is it from the dentate line? So we really can't see the dentate line on MR. It's approximately 2.5 centimeter from the verge, but we can see the anatomy so well. So the junction where the deep component and the superficial component of the external sphincter is meeting, that is approximately the dentate line. So we can give you an idea how far or how away is it from the dentate line. So this is how we look at anatomy. The other thing what we mention in our report is the clock position. So this is an axial image. So lots of surgeons don't understand this clock position, so I'm trying to tell you about that. So anything anterior towards the symphysis is 12, anything posterior is 6, left is 3 and right is 9. So even if you don't understand this clock position, because we have so much interaction with our surgeons, any case they come and discuss with us. So as long as we tell them, oh, this is anterior, this is posterior, that is adequate information for them itself. But this is the clock position we use when we are giving a report. Grading of fistulas have been done excellently in our previous talk by Dr. Rajdeep, but just for the sake of repetition, this is the Parkes classification which you surgeons follow. And here it's very simple. It's basically just showing you whether it's a superficial, is it a intersphincteric fistula, is it a transsphincteric fistula, or is it a suprasphincteric or supralevator sphincter fistula. So now this is an excellent, but it has its limitations. It's not letting you know, are we dealing with any abscess, any ramifications, any other findings? So what we radiologists believe in is the St. James classification. And this has already been told to you, but just for the sake of repetition, because this is important, this is what our reports will have. So we divide it basically into 3 categories: the intersphincteric, transsphincteric, and the rest which are not intersphincteric or transsphincteric. They can be supralevator, suprasphincteric. So the intersphincteric is further divided into the 2 grades, grade 1 and 2. The simple one is the grade 1. Grade 2 is the complex one. That means there's an associated ramification or abscess. Similarly, transsphincteric is 3 and 4. And if it's simple, it's going to be 3. If it's going to have any complex, it will be 4. And 5 is a supralevator and suprasphincteric. So all our reports, a radiology report, will have this grading system and not the Parkes classification. So let's see how we look at each of them. So now look at this. This is definitely in the intersphincteric space. You have an external sphincter. This is the internal sphincter. And this is a simple linear tract. So simple linear tract is intersphincteric. So intersphincteric means basically everything is based on the external sphincter. If it's not piercing the external sphincter, it's limited to the intersphincteric space. That is your 1. If there is an associated complication in an intersphincteric, like in this case, this is an intersphincteric fistula. It's not crossed the margin, not gone into the istioanal fossa, but you have an associated abscess. So this will go into a grade 2. Grade 3 and 4 are transsphincteric. So if you have a simple transsphincteric, that means you can see it has transgressed the external sphincter. It's come into the istioanal fossa, but there are no ramifications, no abscess. So this is your grade 3. If it's a transsphincteric with an abscess, like you can see here, this is transsphincteric, internal opening seen in the 5 o'clock axis, but this does have ramifications. There are small pockets of collection. So this will go into your grade 4. Fistula, which is supralevator, translevator, suprasphincteric, is all grade 5 for us. So here you can see a fistula which has gone really high into the levator on the left side. There is a supralevator component here. So this is a supra or a translevator disease. So this is into a 5. If you have the tract going above the level of the sphincter complex and then tracking down into the intersphincteric space, this is suprasphincteric, and this will also be grade 5. MR is also excellent to look at complications, but yes, clinical history is very, very important for us. So here you can see there is a fistula in the left isthioanal fossa, and you can see the seton inside. But the component of the seton which is supposed to go in is not being seen. But this history and this we need from you, and then we can also interpret. Interpretation becomes much easier for us. Abscesses are excellently delineated on MR. There's an abscess posteriorly here, and you can see it is going through the sphincter complex. And you can see if you just look at the anterior image, this is looking like a normal image, but the abscess is posterior. And for this, we use our fat sat images as well as our diffusion weighted images, which delineate the abscess as well as if there's any communication with the anal canal. Pilonidal sinuses, any complications associated with it, are they communicating with the anal canal? Is there associated osteomyelitis? Are very well picked up on MR. Fistulas also, this is a case of anovaginal fistula. Here we've given vaginal gel, and you can see this fistulous communication very well. The sphincter anatomy is also excellently delineated on MR, whether there's any atrophy, fibrosis, defect. You can see a defect here in the external sphincter. What is the length of the defect? Is there any associated fibrosis? That is excellently shown. Another case showing you a fibrous tract going right up to the levator on the left side. There is no fluid in the tract. You can see the puborectalis sling is also totally fibrosed. And you can see fatty infiltration in the sphincter complex. So the anatomy is excellently delineated. So to summarize, radiologists play a critical role in showing the anatomy of the sphincter complex. The internal opening is excellently seen, the ramification, the abscesses, all the hidden areas which you can't see clinically are shown on MR. The degree of involvement of the surrounding pelvic structures is seen very well, and it helps the surgeon in deciding the surgical technique, which is individualized according to the type of the fistula. Thank you very much. If there are any questions, I'll be happy to take them.
Yeah. Very nicely presented and explained to the audience about the role of MRI and in delineating the track of the fistula. If any doubt anybody has, she'll be pleased to answer to your questions. Yes, please.
All fistula and annals require an MRI.
Yes, I think this question should be answered by the surgeons. But yes, I feel we give you a lot of information and there are a lot of surprises sometimes. But I think the question should be answered by the surgeons, not me.
Can I?
Yes, please. Please. No, this is a very important thing.
As per
Do all fistulas need MRI?
No, probably not. Yeah. And the guidelines by the American Society published are that if the external opening is 2 centimeters away from the anal verge, if you have a posterior horseshoe-shaped fistula, if you have a recurrent fistula, if you have a complex fistula on examination, that means by associated abscesses, a supralevator abscess suspected, or you have fibrosis in the anal canal because of previous surgery, these are the patients probably you will get the maximum yield from MRI. Otherwise, for a very simple fistula, straight fistula, where you can feel the induration under the skin, and it's very close to the anal canal, probably you do not need MRI. But yes, at times, surprises, as the madam said, the surprises may come. Once I thought it's a fistula, it is a simple horseshoe-shaped fistula. When we got the MRI done, it was a bilateral synchronous intersphincteric fistula. We were thinking it is a transsphincteric horseshoe-shaped fistula. Anterior horseshoe doesn't require much of MRI, but posterior horseshoe you require a MRI because there are 2 spaces posteriorly. One is in the deep intersphincteric space and other spaces out of the sphincters. We think most of the time that there is a breach in the external sphincter in the same line 6 o'clock, and then fistula bifurcates into 2. actually, contrary to this popular belief, 70% of the time, first there is an infection spread in the intersphincteric space, then it breaches the external sphincter at two places. And that's where we miss. And that is probably where the lift doesn't work. Why lift has so much failure in posterior, these horseshoe-shaped fistulas, probably that is the answer. And that is the answer where you actually go for a MRI. I'm clear or?
Actually, MRI is very important if you use our old Goodsall's law. The Goodsall law, if all anterior can be avoided and all posterior should be done.
And the guidelines are very clear, as Dr. Kamal said and Dr. Rajiv said. Any fistula which is not simple needs MRI. Simple is intersphincteric or involvement of external sphincter less than 30%. So, or complex. Complex will include recurrent. Complex will include fistulas with IBD, Crohn's, tuberculosis, radiation, malignancy, and failure of previous surgery, anal canal scarring. Put simply, they are all complex fistulas. So, anything which is not simple. Simple is intersphincteric and less than 30% of external sphincter.
But how will you decide that before MRI? In some cases, you should.
Now, how do the general surgeon assess it clinically so that he go for the whether to advise MRI or not? That should be the message for the younger generation.
I think a lot of guidelines are also made depending on cost and availability of the modality. Even in the United States, there is a problem with cost and the time that a patient would take to get an MR done. But I think that if a patient can afford an MRI, it is easy for him to get it done. There is no harm in getting it done. And I'll tell you why. That even for a simple intersphincteric fistula, sometimes you might miss a small extension, supi cephalid, right? And that sometimes gives a very surprising recurrence unless you're very careful to scoop out all the granulation. So that I think is an easy dogma. If the patient is a borderline affordability and your clinical examination is a simple fistula, absolutely don't get an MRI. But if it's an affording patient, even if it's a simple fistula, for a clinical practice, I think there's no harm in getting it done.
Okay. I have two small questions. One is that how often have you found exception to Goodsall rule by locating in external and internal opening? And second, seeing a number of MRI films is overwhelming for a surgeon. So what is one picture that will tell give most of the information?
So like I told you, it's not one picture, but if you see the coronal, I think that is what you're used to looking at. And you will have to look at the fat suppressed images if you're looking for a patent fistula. So that would be the thing. And about surprises, we've seen lots of surprises. We've seen clinically, you've written it's a simple intersphincteric and we find it complex. So I mean, I'm a radiologist, but I would definitely advise that you should, if it's available and like the cost and the time is available, I think you should get an MR because we've seen lots of surprises. We've even seen tumors which are now fistulating, which were not diagnosed clinically.
I have two comments. One thing is that there is an excellent article in DCR which has said that in 40 to 50% of the cases after MRI, your plan of treatment is going to change because you might diagnose undetected abscess, you might detect secondary tracts, so that is why your plan might change. So that is why after I read that article, I have started doing MRI for all my patients unless until it's a subcutaneous or submucous fistula, which I can palpate easily. That's one thing, that's one comment.
One more comment, please.
Yeah. My second comment about the Goodsall's rule. Goodsall's rule is true only for 65% of the cases. It stands true. So always we cannot go by the Goodsall's rule. So in patient where there is a deep-seated fistula, MRI is essential. Third thing, when you are doing MRI, MRI is like a GPS. Okay. Rectum is a three-dimensional structure, so we require all three images. We require an axial image, we require coronal image, and we require a sagittal image to know how the track is going. We cannot depend on one section only.
And now we have 3D coming up, 3D colored images. So hopefully that'll answer and you can see that one nice image for you. Yeah.
Ma'am,
Yes,
does transrectal ultrasonography have any role in fistula diagnosis?
So yes, transrectal sonography is there, but I told you again, the field of view is small and you will not be able to look at the supralevator areas. It's painful. You're inserting a probe inside And this is the easiest way to delineate is MR, because there's nothing, there's no intervention. But yes, internal opening, the accuracy is higher for a transrectal ultrasound vis-a-vis this, but the surrounding anatomy, the surrounding information is not there.
Continue like that. I will request the limited questions because of positive time.
Dissipating after a distance of 4 centimeter. So if your external opening is 4 centimeter away from the rectum, your signals are going to be very, very weak and you will not get the necessary information.
There is no comparison MRI with that. It is very clear. Dr. Chopra would like to say something. You want to say something also? Okay, please, short comments, please.
I just wanted to make a small clinical comment that we should train our fingers well to feel the tract of the fistula in the subcutaneous plane. Because if you can feel the whole tract, that means you're dealing with a low fistula. If you're able to feel only a part of the tract and thereafter it dips in somewhere, that means it's going through ischiorectal fossa elsewhere. So, digital rectal examination still has it.
Just a humble submission. I will stand by the radiologist. Whenever we order for MRI for a fistula, we should not just write MRI pelvis. It becomes very confusing for the radiologist, because when they do MRI for fistula, they do take oblique axial, oblique coronal images after a sagittal image.
Are you a radiologist too?
No, I'm not a radiologist. We are facing a lot of problems for fistula, that's the reason. We should get first a sagittal plane, and then we judge the obliquity of the anal canal, and then according to that we do a axial, oblique axial and oblique coronal image. If we take a straight image, that will not make the whole track of the fistula will not be seen on the one film, and that's the reason that we get so much confused.
Absolutely.
So I request all of you, together with the standing by the side of the radiologist, that you please tell the radiologist that you want not a MRI pelvis, you want a MRI for fistula, and that's why how they can do that.
And our protocol for everything is different. For a fistula is separate, a rectum is separate. So when people actually write and say MR of pelvis, we don't know what they really want. So clinical information is very important, but in our hospital, we interact a lot. So even if they don't tell us, we call them out. Yeah.
Ma'am, just one last thing. A couple of wish lists that I have for radiologists. The biggest problem that a surgeon has, the main problem in fistula surgery is, the biggest question for me is how much of the external sphincter is involved. And that is rarely there in the MRI report.
I agree.
I wish there were a point that you could tell us what percentage of the sphincter lies below the point where the tract is piercing the sphincter, number one. Number two, as surgeons, MRI images are not very friendly to us as general surgeons, right? I think that, I don't know if you agree with me, maybe strapping the buttocks before you do an MRI might give us more surgeon-friendly images, because that is how we see the patient. Especially in coronal, sometimes we have a problem because when you image the patient, the buttocks are just, close together to each other. While when we are examining and operating, they're wide apart. So just these two things.
That may be a little issue because we use coils. So I'm not sure, but yes, the point well taken. And I agree with you. Now we've started doing that, giving how much of the sphincter complex is involved and how much is the length of it. Yeah.